Ooh, Arlena, I really like that one. Art supplies. That's a nice one. Chocolate. Nice. Welcome everyone to our November Learning Collaborative. If you're just joining us, as others are doing, please put your name and your organization into the chat. And then your answer to our question, if you were a tree and you could grow anything, what would you grow? I'm gonna jump in and say that I would grow Reese's peanut butter cups. That would be clear choice number one for me. Nurses and oxygen. What would we do without those two things? Thank you for checking in. Again, for the folks that are joining, please put your name and your organization into the chat, as well as your answer to that question on the top bullet point there. We're just going to give it 2 more minutes before we get started with the session today. Yeah, a coffee bean bush would be awesome. I would love that in my backyard. That'd be great. Awesome. Thank you so much, everyone, for joining us today. I still see people are still kind of trickling in, but we can kind of get started. If you're just coming in, as we get going, please feel free to put your name and your organization into the chat as we get started here. We have a special focus today on resources and information for serving veteran and military involved patients. And we have Dr. Brienne DeBeer here today. Are we good to get going? All right, awesome. Well, I will go ahead and turn the floor over and stop sharing my screen here.
Good afternoon, everyone. Thank you so much for joining us today. I'm very delighted to be here presenting to you all, and just want to say a huge thank you to all for your commitment to suicide prevention. And I'm sure all of you have spent a lot of time in this process of zero suicide and working to make your organizations provide more competent suicide prevention care to those in your systems. And it's a lot of work, and I just want to say thank you for your commitment to doing that, because it's really important. And in the past, we probably haven't been as responsive to suicide as we are now. And it's exciting to see all these developments and so many people being involved in this. So I'm Dr. Brienne DeBeer. I direct a national center within the VA Patient Safety Center of Inquiry Suicide Prevention Collaborative. And I am a clinical research psychologist at the Rocky Mountain Mental Illness Research Education and Clinical Center, better known as MIREC. And for those of you who don't know, there are MIRECs across the country that focus on various issues. The one that is in Colorado, located in Aurora, focuses on suicide prevention. And there's only one other center of excellence in the entire VA that focuses on suicide prevention. So we happen to have a very high-level local resource in veteran suicide prevention within Colorado. I'm also a visiting associate professor at University of Colorado Anschutz.
Dr. DeBeer, really quick. I think you may want to stop screen sharing and start again. I'm just seeing a little bit of text that says you started screen sharing, but I don't see your slides yet.
Oh no, thank you. Thanks
Others
for that.
are having that problem too. Sorry.
Okay, let's see. Let's try this again. Okay. Apologies. Okay, is it working now?
It is for me. I see your slides, not in present view quite yet, but yes.
Perfect. Okay, so this is just a general disclaimer and disclosure slide. So the views expressed are my own and don't represent the views of the VA, University of Colorado, or any other affiliates. I have no conflicts of interest and just want to acknowledge my funders. Very grateful for their funding to do this work. So I'm going to talk a little bit about providing culturally competent care to veterans, talking about staff training and screening for universal suicide risk and universal screening for veteran status. I'm going to talk a little bit about my work in trying to understand how social support can protect against suicide risk and kind of what we observed during the pandemic and some of our more cutting edge work in trying to boost social support within lethal means safety. And I'm also going to talk a little bit about connecting with the VA for support in terms of our suicide risk management consultation line and our new reach out campaign. So as all of you know, suicide remains within the top 10 leading causes of death, and approximately 17 veterans die per suicide every day. So this remains a very significant issue. A couple of years ago, I was at a community event, and actually somebody else said this more recently to me too, that the VA has done nothing for suicide prevention in veterans. And I'm sure that I'm biased because I am in the VA, but I'm also a veteran family member and friend. And I'm also somebody who's very familiar with the VA's program. And the VA has actually done quite a bit in terms of suicide prevention. To me, probably if you look across healthcare systems, probably the top system for veteran suicide prevention in the world. And these are just a few examples of all the things that the VA has done in response to veteran suicide risk. Certainly, one veteran death by suicide is too many, and we have much road to travel in continuing to improve our processes. However, on the flip side, to say that the VA has done nothing is just not accurate. And this is an old graph, but I like it because it shows the percent increase. So between about 2005 and 2017, we see a very sharp rise in civilians. That's the top line, so about 43% increase. Whereas in veterans, we only see a 6% increase. So we think that some of the things that we've done have been working, but it's very difficult to test these types of things in terms of research. So here's a newer graph. This is the 2021 data, which goes back to 2019, and we actually do see a tapering off in both veterans and civilians. Who knows what's going to happen during the pandemic? My prediction based off of prior data would be that suicide deaths go down in 2020 and rebound in 2021, because suicide deaths tend to follow the mortality from infectious disease in pandemics and epidemics. Okay, I don't really need to tell you all what a learning collaborative is because you all are engaged in the process of a learning collaborative right now. But we in the VA are piloting a learning collaborative on veteran suicide prevention. And these learning collaboratives typically bring together healthcare organizations or other organizations who work together to implement a best practice. There's a lot of evidence indicating that these learning collaboratives are effective. So in our learning collaborative, we have a process of 6 quarterly meetings with all organizations and monthly facilitation calls where we focus on implementing suicide best practices. And what has come from this, we have this process of, we do an organizational self-study to try to understand what's going on in an organization. We do a blueprint. So what do you want to change about the organization and how would you go about doing that? To think through implementation pitfalls on the front end. And then we create an action plan, which is kind of like a project plan. How are we going to be implementing this in your organization? So typically we start with training. So military cultural competency training for staff and providers. We recommend this as a first step. And this is available through Psych Armor, which the Governor's Challenge has, gotten together in Colorado, which has been a really amazing resource. And then there are also resources available on VHA Train, For those of you who don't know, VHA Train is a large platform that provides the entire online library of these training resources for free, including free CEUs for clinicians. And there are a lot of free resources in there regarding suicide prevention, PTSD, military cultural competency. I highly recommend that you all check that out. There's self-paced trainings. A lot of the time, the VA also has different webinars, and those webinars are also cataloged within VHA Train. So it's a really wonderful resource for agencies. Again, everything is free. The trainings are free, the CEUs are free. And we also recommend that everyone take SAVE training as well, which is also embedded in the VHA platform. So through this process of the Learning Collaborative and working with these community organizations in the Denver, Colorado Springs area, we started a process of for organizations who wanted to, not all organizations wanted to or were able to, but for organizations who wanted to, we started supporting them in processes of implementing screening for veteran and veteran family member status and screening for suicide risk. So how does this go when you're trying to do screening for veteran and veteran family member status, and why would you even want to do that? So we, in the process of the Learning Collaborative and talking to people, one time I was talking to somebody from an organization who was a veteran, and he said, I don't really see a reason to try to understand if people are veterans or not. And I think that that's a really great question. Why would we even want to do that? And could we be singling people out? Well, we know from our statistics that veterans are at much higher risk for suicide. We also know that veterans have other risk factors for suicide that are different than civilians. Veterans have other experiences that are different from civilians. And we need to be actively addressing that through creating communities that are ready to receive veterans when they discharge from active duty military. And I was talking to someone recently, and we both said, is there a community that's ready to receive veterans? And I don't really know of anyone off the top of my head that have, a web of organizations working together that provide high levels of military culturally competent care, adequate resources to veterans, and support. And I think that we can all, continue to improve and do better at this. And one way to do that is to understand factors that are different in veterans versus civilians, and provide care around that. And one way to do that is through screening. Why would you want to screen for veteran family member status? Well, there are a lot of children who have been impacted by their parents' service and by their parents' mental health. I would also like to say, I also say this, I don't think that, not every veteran experiences mental health symptoms, certainly. But we do know that in our combat veterans, about, 25% are coming back with post-traumatic stress disorder. So there is a sizable minority that do experience mental health symptoms, and they have children and families, and this really strains those relationships. And so to understand, a child or a family member's, the fact that they have, a veteran in their family may point to certain programs or resources for those family members as well. And so, we recommend in this process, establishing a process for how your organization will screen for veteran or veteran family member status. So what information do you want to collect? Do you just want to know if they're a veteran or not? Or do you want to know more information about their military service? So if you're somebody who's embedded within a community mental health center that may have, treatments for PTSD, you may be running a combat PTSD group, you might want to know if this person has combat service versus, veterans who don't have combat service, because you may recommend this person go into this specialty type of care. So you may want to know more information about their service in order to be able to provide more offerings to that person. We recommend, specific wording on screening Like, did you ever serve in the armed forces versus are you a veteran? So my dad served in the armed forces, but he does not identify as a veteran, and he's actually ineligible for VA care. So not all veterans are eligible for VA care. And so, if I asked him, did you ever serve in the armed forces? He would say, well, yes. And I would say, but are you a veteran? And he would say, no, because I don't qualify for any VA benefits. And they told me that when I discharged. So, there's a lot of complexities here around, and this is something that we could talk about for hours and hours, and we only have so much time and so many topics to cover during the period. But happy to have conversations with people if they have more questions about this. You really need to get your staff trained in these screening procedures and kind of understanding why they're important. What are the procedures? How is this going to be done? And that is where the prior training comes into play, making sure that staff has training in military cultural competency to, be responsive to veterans is really important. And one of the great things about once you start doing this and hopefully being able to collect data around screening veterans, you can use that data and information to drive changes to your organization. So one of the organizations we worked with, we found out that they had a huge number of female veterans. They did not realize this. And so now they're starting to cultivate some specialty programs and get their staff trained in other treatments to be able to provide to these veterans, because they did not realize that they had such a large group of women veterans who, again, have different experiences, have different needs, and need culturally responsive care. And so another great resource is the VA Community Provider Toolkit. And this is the website, and this is just a screenshot of the homepage. But there's asking about military experience is one choice. But there are other choices like working with veteran populations, supporting veteran mental health and wellness, and navigating veteran benefits and services. So there are a lot of really great resources here. You can navigate to asking about military experiences, and there's more information there on what to do and how to implement that in your organization. Oops. So similarly, screening for, So similarly, screening for veteran suicide risk, we recommend this only if your organization has a licensed mental health professional on staff to be able to receive veterans who are at risk. We did this with several organizations. One of the organizations, even though they had a licensed person, wanted to start with screening for general mental health and then escalate it to screening for suicide risk if somebody was positive there, which is also a good step, trying to, depending on your organization, trying to understand if somebody is experiencing current mental health symptoms. It's important to establish a process for when your organization is going to screen. Will they be screened upon intake? Will they be screened at every contact? What does that look like for your organization? How are you going to screen? There are a number of different tools. These are just a few examples. So are you going to use the Patient Health Questionnaire 9, which has a question about suicidal ideation on it? Are you going to use the Columbia Suicide Risk Severity Screening Measure, which has much more in-depth questions? What is that going to look like for your organization? Once somebody is positive on those, what does that look like? We recommend further evaluation by a licensed mental health professional and then connection to resources. So one example was that we implemented this with a large veteran service organization who, had a lot of veterans coming in for various needs. So they offered a number of services besides mental health, but they had an internal mental health wing with licensed mental health professionals there during all operating hours. And so they started screening for suicide risk, and they were able to have veterans receive a secondary screening and then provide them with mental health services. And just within a few months, they had already screened 300 veterans and had 20 positive that were not receiving mental health currently, and that's in Colorado Springs. And so you can see how if this can be implemented effectively, although it is tricky, we don't recommend if you're an organization that has no mental health, that has no in-house, we're not necessarily going to recommend something like this. But if you're like this veteran service organization where you do have the tools to do that, it might be a good fit for the organization. Again, staff need to be trained very well in these screening procedures, and we supported our organizations in making sure that their staff was trained through this learning collaborative process. And, again, a lot of organizations are using this data to drive changes to their organization. And that's a really ideal situation if you can, if you're able to collect data on this. Not all organizations have that capability. And then be able to say, wow, we screened 300 people and 20 were positive. That's almost 10% of our people coming through are positive. We need to keep doing this and making sure that we have adequate resources to provide to these veterans. Because if we think for our veterans, Colorado Springs has one of the highest rates of suicide in the country. And if we're thinking about, all these veterans are falling through the cracks, like these are ways to stop them from falling through the cracks, to catch people and connect them with care. So this sounds great, but I want more help. We are actually starting up a new collaborative for organizations who accept VA community care or Tri-West. And feel free to reach out to me. That's my email address if you're interested in implementing something like this in your organization or other veteran suicide prevention best practices. We've talked about this, and our learning collaborative seems to be pretty complementary to this learning collaborative because we're really more focused on the veteran angle within suicide prevention and really helping organizations cultivate a niche area in veteran suicide prevention. Okay, so that isn't all that I do with my life, although I love it. I love doing the learning collaborative. I'm also really interested in social support and how social support is a buffering factor. So this is some of my prior work, and what we determined from this work was a nice moderation effect, where we looked at veterans who've been deployed to Iraq and Afghanistan, and for veterans who have high social support, that's this dotted line down here, what we see is that if they have low PTSD and depressive symptoms, they're not having much suicidal ideation, which is the left-hand axis. But if they have high PTSD and depressive symptoms and high social support, they also don't have much suicidal ideation. Their social support buffers that suicide risk. But when we look at veterans who have low social support, this solid line, again, they're not having many symptoms, not having much suicidal ideation. But when they're having PTSD and depressive symptoms, their suicidal ideation spikes in that absence of social support. So social support can protect against suicide risk. So when the pandemic started, we thought, well, this social distancing is probably going to impact social support. Let's do some research on this. And we applied and got some funding from the VA. We know that social connectedness is critically important to wellness, buffers against suicide risk, some of my work. We also know that public health mitigation strategies have been necessary to slow the spread of COVID-19, including social distancing and quarantines. And research coming out has already demonstrated that this social distancing and quarantines have had negative impacts on mental health and well-being during the COVID-19 pandemic. So I think it's something that's very hard, right? And Colorado is experiencing a spike of cases right now. Excuse me. On the one hand, this is a deadly illness. Unfortunately, over 700,000 of our fellow Americans have died since the start of the pandemic. So these things are necessary. On the other hand, there are unintentional consequences on mental health and suicide risk. So we were very interested in trying to understand that. We also knew that these happenings could impact a veteran's ability to access needs such as transportation and healthcare. And the pandemic also increased needs around things like employment, food, security, and finances. And these things are risk factors for suicide. So There's also another wrench in here in the decreased ability to engage in some coping strategies, like group exercise or group social events or going to concerts and things like that. So you have this wonderful combination of an increase in risk factors for suicide with a decrease in coping strategies. So when you're a clinical psychologist like me, you never want to hear that. It's not good. So our aim was to investigate the impact of the pandemic and social distancing on one's support system via social network analysis, as well as impacts on needs. So we partner with Visible Network Labs. Danielle Varda is the CEO, and she's also a professor at University of Colorado, and she's incredible. And she's really pioneered a lot of methods of social networking analysis, and very fortunate to work with her. We had 233 veterans enrolled in the VA. We recruited them through targeted mailings. We oversampled for mental health diagnosis, positive COVID-19 diagnosis. We did a one-time 90-minute online survey. So social network analysis identifies personal support networks, including organizations and healthcare providers. It assesses type, trust, dependency, support, importance, and networking. So how are the members networked together? We assess changes in the network that occurred during the pandemic. We assess changes in needs that occurred during the pandemic. We also asked them who can in the network can assist with their needs. And we asked about the network prior to the pandemic. So prior to March 2020 and the present. And the present was November 2020 to January 2021 when we were collecting this data. Veterans perceived their mental health to be worse since March 2020. The most pressing new needs since the start of the pandemic were health needs, behavioral health, and finances. 31% of veterans had 4 or more pressing needs, like mental health, behavioral health, finances, general physical health, transportation, food security, things like that. We found that social support networks did not address needs. Most veterans could not identify a network member to help with their needs. 78% could not identify a network member to assist with healthcare needs. 63% could not identify someone to help with mental health needs, which was pretty stunning to me. I honestly did not expect it to be that high. We conducted a path analysis to better understand the associations between these variables. And what we found was that, so we're also interested in something that's called social cognition, or the skills that underlie social interaction. If people have poor social cognitive skills, it likely means that they're unable to garner social support. And that is what we found. So all of these pathways are positive, but they are in the expected directions. So if somebody had basically low social connectedness, which is associated with high values on this scale, they had higher PTSD and depressive symptoms. And if they had higher PTSD and depressive symptoms, they were at higher risk for suicide, experiencing higher suicidal ideation. If they had poor social cognition, that was associated with lower social network. So they had more adverse social connectedness. And social cognition was also associated with increases in PTSD and depressive symptoms. So veterans do not perceive their network members to be working together to coordinate mental health and healthcare needs. And so one of the things that I'm working on is, how do we harness network members in service of suicide prevention? Excuse me. Adverse social connectedness was associated with mental health symptoms and suicide risk. It was an indirect association between the adverse social connectedness and suicide risk. The association is worse in individuals with hostile attributional bias. So social cognitive interventions may improve this risk, but that is to be tested. So a couple of years ago, I conducted some work looking at involving a concerned significant other in safety planning for veterans. And maybe I'm sure most of you are familiar with safety planning, but it is a frontline intervention for suicide risk in veterans and civilians. And so, again, we know that social support mitigates suicide risk. So we asked veterans and their concerned significant others, we call them CSOs, do you want your CSO involved in your suicide care? And the majority of veterans and all CSOs wanted involvement of the concerned significant other in the veteran suicide prevention care. This was a sample collected from Central Texas. Surprisingly, there were similar findings for CSO involvement in limiting access to firearms. So veterans and CSOs wanted to be involved in that process. So we applied for and received funding to develop a CSO-involved firearm safety intervention to increase secure storage among veterans far in advance of a suicidal crisis. We refined the intervention and wanted to understand optimal conditions for implementation. So we're going through, we've completed objective 1. We're working on objective 2 right now. In the United States, we have a culture that's oriented to creating plans for safety. And more recently, now that we've kind of been, I've kind of been going places. I have a small child, so we did not go anywhere for a year and a half. And so more recently, we've been starting to go places, and I've noticed this more and more in buildings are their safety plans. You know, you are here in the building, the fire exit is here. This is something that we do on quite a regular basis, is to make these plans for safety. So hurricane plans, fire plans for your home. If there's a fire in your home, everybody meets at the tree in the front yard. Tornado plans, do not resuscitate orders. So I recently was asked, do you have a do not resuscitate order? We want to come to you now while you are well and in sound mind and ask you what you want to do in this situation. But for some reason, we don't have this around firearm safety. And we know that 2/3 of veterans who die by suicide use a firearm to die by suicide. So if we want to solve the problem of suicide in veterans, firearms are really a linchpin here. So what we're working on is creating a safe storage plan with veterans. So we have a veteran and a concerned significant other sit down. The veteran may not have any mental health symptoms. Far in advance, we want to say, okay, if you or someone in your home had a mental health crisis, how would you handle this? How are you storing your firearm now? Could you be storing it more safely? And if there was a mental health crisis in your home, how would that change the way you're storing your firearm? So, you know, what's your plan for safe storage when there's no mental health crisis? What are some of the warning signs when a mental health crisis might be building? And involving the concerned significant other in this. How is the dyad going to communicate about these mental health warning signs? You know, a lot of times we don't know how to talk to each other about mental health symptoms, and that's really problematic. So having a conversation in advance about how you're going to do that, I think, is important. So if somebody's experiencing a mental health crisis, does that change your safe storage plan? It might not. It might not. And if a crisis arises, who are you going to contact to help with this? And so we've developed the manual, we piloted it on 5 dyads. We continue to pilot it. We just received funding to pilot it on an additional 30 dyads. And it's been interesting. It's, you know, we always learn from this process. You know, I'm always learning from the veterans. And, you know, some people say to us, you know, I've never thought about this before. I have an adult child who has severe mental illness and he can access my firearm. And that probably isn't a good situation for us. So maybe I need to think about, you know, some more safe storage. And that's what we want. We just want people to be thinking about in advance, you know, how would they do this? If you know of somebody who might want to participate with us, please feel free to reach out. Again, it's a pilot project that we're doing to see if this is effective. And, you know, we've had other situations where somebody said, wow, I hadn't thought about this, but, you know, my young grandkids can actually access my firearm. I just didn't think about it. You know, we just want people to stop and slow down and just think this through. And they might think it through and say, you know, I'm good with how I'm storing things. That's fine. We're not here to take anybody's guns away. We're not here to, you know, that's not what we're trying to do. What we're trying to do is trying to see if we can change things a little bit. Can we reduce that suicide risk or other risk for harm within the home? Okay. So, you know, we in the VA, I guess I'm speaking for the VA, we want to connect with all of you. We want to be collaborating with you. And I think that currently we are a different VA than we have been in the past. You know, when I started doing more community-based work about 4 or 5 years ago, and what I was hearing from my colleagues in the community was, you know, VA doesn't really want to collaborate with us. That's the feeling that we get. We get the feeling that the VA just has no desire to collaborate with us. And I think that that is not a good state of operation for the veterans. The veterans exist in multiple systems, and we all need to be working together to make sure that they have everything that they need, they have the resources that they need, and that they're being provided with excellent care. And we can only do that if we're all working together. And there have been a number of proclamations and changes made within the VA where at the top, leadership is saying community collaboration is extraordinarily important, and we recognize that the only way to properly take care of the veterans is if we're collaborating with the community. So if you've maybe had an experience like 10 or 15 years ago where you got the impression the VA doesn't want to collaborate, I think that there's a lot of change occurring, and I would ask that you give us a chance again. We're certainly not perfect. I'm not trying to say that, but I think that things are changing quite a bit. We've also really gone through a lot of effort to create resources for the community. I've shared a few of them so far, but there are many, many resources available, particularly for veteran suicide prevention. And we're actually working on a compendium or a toolkit of resources right now. And I'm happy to disseminate that and share that with the group once we've finalized that. Because probably if I were to go through all of the resources available, we would be here for about 10 hours or so. And I know that nobody has that kind of time. So you can just read our toolkit, which should be coming through fairly shortly within the next month or so. So a huge resource that I want to talk about, it's a national resource, but it's located locally in Colorado, is the Suicide Risk Management Consultation Program. And oh no, I thought that this link made a link instead of writing out what it is. But if you Google VA Suicide Risk Management Consultation Program, it will come up. And the slogan for our Suicide Risk Management Consultation Program is never worry alone. And so this program provides free consultation and support to clinicians, providing services to veterans who risk for suicide. So you could be a VA clinician, you can be a community clinician. We provide free consultation either way. So this is just a sample of a screenshot of the website. And so there are a lot of different resources on this website. More recently, in the past year or two, we've started suicide risk management lectures, and those are recorded and then posted on the website. So you can go and watch those, which is really great. And there's more information about how this process works and other tools and training resources that are available for free. So if you are a clinician and you're interested in a free consult, you go to request a free consult and you go to start here. And what that is going to do is bring you to this page. You go to request a consult, and that'll pop up an automated email in your email that you can send a request to the consultation service. And they will get back to you within 1 business day regarding how to move forward. And they provide support on these issues. So risk assessment, conceptualization of suicide risk, lethal means safety counseling, strategies for how to engage veterans at high risk, and best practices for documentation and provider support after suicide loss, so postvention. So there are a lot of varied resources available here, and they're really wonderful and highly recommend reaching out to them. This is an example of a recent lecture. Something that's interesting that I've noticed is that I don't know that a lot of community members know about all of the free lectures that we have in the VA. This is just one example, but there are a lot of different free lectures within the VA, on probably a weekly basis. And so these are some examples of those, and many of them offer free CEUs as well. I'd also like to talk about a new campaign the VA has. This new campaign is called Reach, and there's the website that you can go to see more about it. But basically, it is a website that provides support and resources to veterans, and it's designed to help with a variety of different issues. Excuse me. And so you go to this main web page, and then you click on Get Support and Resources. Oops. Oh no, did it? Oh my gosh, I guess this slide, oh no, that slide got deleted. It steps through a process of trying to understand what a veteran needs support around, and then gives specific resources to the veteran. So if you work with veterans, clinically who need resources, highly recommend this as a resource to them as well. And then again, feel free to reach out. So this is my email address. I have a number of different collaborators, and just very, very grateful to them for the work that we do together and their support of these projects. So somebody said to me, "This is your brainchild," about something I was doing. I was like, "It is not my brainchild. This comes from a lot of meetings, talking to people who are smarter than me, and getting their thoughts on things, and a lot of collaboration. There are a lot of people behind all of this work, and very grateful to them for their expertise and support. I have an outstanding staff who works really, really hard for the veterans, and I'm very appreciative to them for their time and their efforts. And we would not be as far as we are without them during the pandemic. They really hunkered down and made things happen and helped a lot of veterans. So very grateful to all of them. And questions. So we have some time for questions and discussion, and I'm very open to any questions or discussions around any of the things that I talked about today, or if anyone wants to have any sort of further discussion, or if I can help support you in any way in your work with veterans, please let me know.
Would it be possible to get a list of those links that you spoke
Sure.
about today?
No problem. Great idea.
We'll also be passing out the links to the slides and recording too afterwards, so you'll have access to that. But yeah, feel free if there's a compilation. Those are some awesome resources. Would love to send those out to everyone.
So I think I see a question: is your learning collaborative open for all staff of the VA, or do only certain people join? So how we have structured our learning collaborative, our first learning collaborative was a pilot. This next learning collaborative will also be a pilot. We're embarking upon a new learning collaborative probably in this like late winter, early spring, maybe like a January, February, March timeframe, depending on, how everything goes. And that is actually open to community organizations who are in the VA Community Care Network, meaning they accept Tri-West. And we are open to any organization who wants to work with us in that endeavor. And basically, we have a core staff from the VA who has expertise in suicide prevention and implementation science. And then we bring in, and they run the collaborative. And then we bring in other people as necessary. So, we might bring in, we brought in people from veteran benefits to help our collaborative members understand the VA benefits process. We brought in our local recovery coordinator to help organizations understand how to specifically connect to, what part of VA. So my veteran has PTSD. How do I get them PTSD treatment at the VA? So we bring in other people into the collaborative, depending on their expertise and the needs of the collaborative as well. So that's typically how we run it. And then all of our collaborative members are community organizations. So again, this time we're going to be doing community organizations who are in some way involved in the community care network, because we recognize that that is another area that could use some strengthening in terms of methods. So we have these veterans who are at risk for suicide who have very specific needs surrounding mental health and other specific needs, things like Gulf War illness and other things that are typically not seen in civilian healthcare systems. Then they get taken out of the VA system and put into a civilian healthcare system who don't understand those specific needs and are not responsive to them. And so, we just want to be working with our healthcare systems to share lessons learned in the VA and help support them in working with veterans, but also hear from the organizations about what their challenges are. So I've learned a tremendous amount, and I'm working on publishing this, about the challenges that organizations face in treating veterans, and how can we overcome those challenges in order to provide excellent care to veterans. So to me, it's a bi-directional process of where everybody learns from each other, and we support the veterans in the best way that we can. I see. Can you speak a little bit more about how the clinical consultation process works? Sure. So I don't serve in this in this service, so forgive me if I get anything incorrect here. I'm not the foremost expert in this, but the clinical consultation process, they'll talk with you about the veteran situation. So, a lot of the time, I mean, certainly I think that I can identify with this. I got very little training in suicide risk management in graduate school. I have a PhD. I got a lot more training on that on my clinical internship. But there are many of us, especially those of us, I'm getting up there in years. I got my PhD almost 10 years ago. And there are many people who got their mental health degrees 20 years ago, 30 years ago, 40 years ago, and things have changed significantly in suicide prevention since that time. And even recently, I was talking with a community member, and she said, I'm a licensed mental health professional. I don't ask about suicide risk because it might put suicide risk in someone's head. And so that was a myth that was, thought to be true many years ago. And research has demonstrated that that is not the case, that if you ask somebody if they're suicidal, that does not, make them suicidal. And so I think that there are, many of us who could use some additional consultation surrounding some of these very challenging veteran cases where people are at high risk for suicide. They may not want to reduce access to their firearm, and their firearm may be, their lethal means of potential choice. There's a lot of sticky issues here, and how do you manage that with your client? And so the suicide risk management consultation program will talk with you about your client, try to understand your client's situation, and then make some recommendations. So they may make recommendations like, we think a safety plan and maybe this type of intervention would be good with this veteran. Maybe there are a lot of times where, should we send out a welfare check for this person? Should we, what should we do with this case? And they provide consultation on that. And a lot of the people who run this are really truly experts in this work of, when do you do a welfare check? When do you not do a welfare check? And they've written a lot of, peer-reviewed articles on these topics. So, they step through a process of consultation with you, and then they continue to follow up. So depending on your situation and the veteran situation, there are follow-up calls to, provide additional consultation. Okay, when you implemented the safety plan, was that an effective intervention with them? What are the issues that are left? And again, this is meant to be supportive. The VA is not trying to tell anybody, what to do or what not to do. It's more a process of consultation. And when you're struggling with a case that's challenging, sometimes it's helpful to talk to people and get support and thoughts about how to address those challenges.
Awesome. Thank you so much for describing more about that process and just these resources in general. I think this will be really helpful for everyone. I'm excited to get these links out. I shared Dr. DeBeer's email in the chat as well, so feel free to follow up with any direct questions after the meeting if they come up to you and yours. We do have a couple more updates as an office to share with you before the end of the day, but I want to hold just a little bit more space in case there are any other lingering questions before going through those. Okay, well, seeing none in the meantime, thank you so much. People have been saying thank you in the chat, Dr. DeBeer, for these great resources and
Thanks
this
for having me.
information, and just your work in general to support veterans and sharing what the VA does. It's really appreciated, heard, and seen, and I hope that there's some opportunities for collaboration in the future. If you wouldn't
Absolutely.
mind, stop sharing your screen, and then I can share some of our updates too quick before we let folks have a few minutes back in their day. One exciting update out the gate, very relevant to our conversation here today, is the launch of Operation Veteran Strong by the Office of Suicide Prevention. So this was created by a Denver-based behavioral health technology company, and Operation Veteran Strong helps connect veterans to tools, resources, and support to foster resilience and prevent suicide via their new customized digital platform. So please access that resource via the link in the slides. Also wanted to flag again the Zero Suicide Toolkit. There are some resources in there relevant to serving veteran populations. Please also see Dr. DeBeer's slides about those veteran screening questions and some of the concerns specific to that population. Also wanted to flag the CDC is still seeking public input on work-related stress for healthcare professionals. You have the opportunity to weigh in with a national network of other healthcare providers by November 26th. There's also a free SBIRT training on November 23rd that focuses on training for providers who are dealing with clients who are using drugs, looking at their screening and brief intervention practices for those, as well as specific to mental health professionals. They have an added component there. And then also again wanted to flag I Matter Colorado, which is a new push from the state and allows for all youth in the state to have 3 free counseling sessions. So if you're working with youth or are aware of where that resource could be used in your circles, please feel free to spread that as well. Other updates, you just heard about these, so I won't go over those again. But our next meeting is tentatively December 21st from 12 to 1, pushing it a little earlier than that 4th Thursday of the month just because of the holiday. And the topic will be hearing from some community mental health centers about getting creative with zero suicide implementation. You'll get an invite for that probably a week or 2 out with a confirmed date and time. But in the meanwhile, please feel free to reach out with any comments, questions, ideas for the Learning Collaborative, stuff you'd like to see discussed. It's not too late to put your name and organization in the chat. Sorry for bugging you about that so many times, but that's how we take attendance. But otherwise, I think we have 5 minutes extra back into your day. Thank you so much for coming today and hope to see you at the next one. Thanks, everyone.